This is part 8 of step-by-step vitrectomy. Continuation of vitrectomy in diabetics. Vitrectomy in different stages of PDR. Three forms of diabetic retinopathy will be faced during vitrectomy. First form is patient with total BVD with vitreous hemorrhage. This patient almost did PRP, so there is total separation of the posterior hyaloid, and the vitreous hemorrhage is dispersed inside the vitreous cavity. This is called mild PDR, and this is the easiest form. The second form is partial anterior BVD with total posterior hyaloid with aggressive proliferations at the posterior bole. This patient almost did partial PRP, and still the hyaloid is attached, and there is proliferations at the posterior bole on the scaffold of this posterior hyaloid. This is called severe PDR. The third form is no BVD with aggressive proliferations all over the retina. This patient almost did nothing, no laser done before, so there is aggressive proliferations from the posterior bole and extending to the extreme periphery, and this is the worst scenario, what is called advanced PDR. This is an example of the first scenario of mild PDR. The patient has total BVD with vitreous hemorrhage. The blood is totally dispersed inside the vitreous cavity, doing a core vitrectomy and removal of the blood clots and the liquefied vitreous hemorrhage. Sometimes there is a difficulty in identification of the retina below, so opening a hole inside this vitreous hemorrhage in the superior nasal quadrant is the most safe site until seeing the retina below and then starting to completely remove the vitreous hemorrhage with landmark of the retina identified after opening of this hole. After total removal of the vitreous hemorrhage, then restaining with triamcinolone. Restaining helps to identify if there is a remnant layer of posterior hyaloid, what is called vitreoschisis, which is commonly present in diabetics. After removal of the precipitates of triamcinolone, then being sure there is no additional layer. After this, staining of the ILM can be done. Removal of the ILM isn't mandatory in all cases, but there is a reported instance of macular puckering after vitrectomy in diabetics without ILM peeling, varying in literature from 10% to 50%. So, if ILM is removed, it is beneficial to avoid the appearance of macular puckering and epimacular membrane with affection of the final besto-corrected visual acuity. Removing of the ILM also helps to be sure that there is no remnants of posterior hyaloid on the surface of the retina. After this, we are doing vitreous-based shaving. Vitreous-based shaving helps in 2 points, helping to remove as much as possible of the vitreous, which is the vehicle of VEGF, which is the main responsible factor for all complications of PDR. Also, removing of the pockets in the extreme periphery helps to decrease the incidence of recurrent vitreous hemorrhage, which may come from liquefied blood from these pockets in the extreme periphery. Then doing PRP. PRP is the mainstay and the main treatment for PDR, so has to be done meticulously. Doing PRP extending from behind the arcades until reaching the extreme periphery. The extreme periphery is so important because it is the most ischemic part and the source of VEGF. VEGF, as known, is responsible for macular edema and the development of new vessels and fibrovascular membranes, so this decreases the incidence of complications. The second case is an example of the second scenario of severe PDR. The patient did previously PRP as we see in the video, and there are proliferations at the posterior bole, not extending to the extreme periphery. So after doing core vitrectomy, then starting to attack this membrane. At this moment, we have to identify well the epicenters, the areas of free bridges. Identification of these points is so important. Then cutting the bridges, which are the free points of attachment between the membrane and the retina, leaving the epicenters in place. These epicenters will be attacked finally when they are free from any peripheral attachments. Catching the forceps and the removing of the membrane from over the disc. If there are bleeding points from the disc, then elevation of the IOP is almost enough to control these bleeding points. When cutting between the bridges, the membranes are isolated into small islands. This can be done repeatedly in different parts. This is an example of a membrane with epicenter attached to the retina. Attacking the membrane with the cutter, the membrane will be folded back upon itself until complete removal of this membrane. Then removal of the eye limb. Eye limb peeling is important in this case because it eliminates any proliferations over the macula, helps to attain a better visual acuity post-operatively. Then completion of PRP. Most of the cases, the laser is not adequately covering the retina, so reaching the extreme periphery within the laser is easier than doing it outside. Also, if there are multiple spaces between the spots, these spaces has to be covered with laser. This can be helped with indentation or done even under air, which helps to see the extreme periphery of the retina. The third case is an example of advanced PDR. The patient didn't do any laser before, so there are aggressive proliferations extending from the optic disc to the extreme periphery. Using the cutter can help to eliminate all of these proliferations. The cutter can help as a forceps, catching the membrane with mechanical force or even with vacuum, and can help as a scissor, cutting the bridges and cutting the epicenters. The most important function of the cutter is to do delamination. Delamination can be done in two ways. The first way is to put the cutter on the surface of the membrane, helping the membrane to fold back upon itself to enter inside the opening of the cutter. This is called fold back delamination. Delamination also can be done with attaching the cutter to the membrane, but this is less safe. This is called conformal delamination. The settings has to be low vacuum and high cutting rate. The trick in this case is to cut all of the bridges. Any peripheral attachments of the membranes has to be removed before attacking of the epicenters. When the epicenters are free from any peripheral attachments, then it is easier to remove it with delamination. When there are bleeding points, we can do a compression with the cutter, elevate the infusion, or if there is intractable bleeding, then a bubble of perfluorocarbon decalin can be put on the posterior pole, helping to make the blood being away from the center of the retina. If there are retinal folds after removing of the membranes, don't try to flatten these folds. These folds will flatten itself within days after removing of the membranes, making a traction in it. The injection of triamcinolone. This helps to identify the remnants of posterior hyaloid at the extreme periphery. Removal OH decreases the incidence of recurrence of fibrovascular proliferations postoperatively. And thank you.